Ready.
Okay. Hello everyone. Thank you for coming today. Unfortunately, I got a cold and I can't speak well very much. So I'd like to introduce Professor Hagen briefly. He is working in University of Southern California. It is a very famous hospital in the United States. And his specialty is esophageal surgery and lung cancer surgery. He will give us a seminar tomorrow about robotic surgery. And today he's going to talk about the acute care surgery in LA County Hospital. LA County Hospital is a very huge hospital for emergency patients. And there's a specialty for doing emergency operation team called acute care surgery. So he will give us about a very extraordinary experience in acute care surgery in LA County Hospital. So let's start the lecture, please.
Thank you, Dr. Hagen, for that introduction, and it really is a great pleasure to be back here at Kumamoto Medical Center, and it's a great opportunity for my wife and I to meet up with old friends, and for me to meet some new people and make new friends each year when I come here to visit. And I will be talking about acute care surgery and giving you a little bit of flavor for what that's like at USC. And these are just some of the memories from a recent trip here. I'm commonly asked by the interns when they come by, and I get to meet them when they pick me up or take me back to the hotel, if I like Japanese food or if I like sushi and all those kind of questions. So just to answer that question once and for all, we do actually love sushi in Los Angeles. And this is my two sons up here in the top making a sushi dinner that we had here, which you can see quite a spread made there. This is my contact information. If anybody is coming to Los Angeles, I welcome you to give me, send me an email, let me know you're coming, and we'll show you around a little bit at our medical center. So before I get into acute care surgery, I just want to give a little bit of a background about the county hospital for those who, for the interns in the group. The first county hospital opened way back in 1878. It was a 100-bed hospital that served the poor in Los Angeles. It was actually called the Los Angeles County Hospital and Poor Farm. The University of Southern California was founded 2 years later in 1880, and the two of those joined together to form the Los Angeles College of Medicine in 1885, which is actually 8 years before Johns Hopkins created a similar model back in the East. This is the hospital that most people are familiar with when they think of Los Angeles County Hospital. It's called LA County General Hospital, and it opened in 1933. At that time, it had about 1,400 beds. It was increased to over 3,500 at the time of World War II to take care of some of the combat wounded. It was at the time and still is the largest teaching facility in the United States. In 1994, we had an earthquake. It was a 6.4 earthquake on January 7th, and it caused damage to the LA County General Hospital, and so they had to begin this project to replace the LA County Hospital, and that facility opened in 2008. It is a giant hospital. It's 3 city blocks long, and it's comprised of 3 separate parts. The outpatient tower, which is 35,000 square meters, where all of the clinical activity at County USC occurs. Over 1 million patient visits per year in this clinic building here. You can see the old county hospital a little bit in the background. And then in the center is what's called the Diagnostic and Treatment Facility. It's another large, it's a 5-story building. It houses our operating rooms, radiology services, and the Department of Emergency Medicine that I'll talk a little bit more about later. And then at the east end is the inpatient hospital tower, 8 stories, almost 65,000 square meters. It's licensed at 750 beds, including 180 ICU beds, the region's largest burn unit, and 555 general medicine surgery beds. This facility is a home to 714 full-time faculty, and it's the largest training program in the United States with 890 interns and residents, more than 40,000 admissions, and a lot of people working there. There's 2 other hospitals on the campus that are within walking distance and an important part of our training program at USC, and the first is the Norris Cancer Hospital, shown here. It's a small inpatient cancer facility, only 60 beds, but a very large outpatient cancer clinic and infusion center, and it's one of the original 8 designated comprehensive cancer centers in the United States. And then our newest facility is the Keck Hospital of USC, shown here. That opened in 1991 at 265 beds. And because this facility came available, we were able to recruit a large number of surgical faculties to support our educational mission. And 80 full-time faculty were recruited in surgery after this new hospital was opened. And finally, we added this tower, Norris Inpatient Tower, in 2007, so we now have just over 400 beds at Keck Hospital. So that's just a little bit of a background about our facilities and programs. So what I'm going to talk to you about tonight is the specialty of acute care surgery. It is the newest medical or surgical specialty in the United States. And I'm going to talk to you a little bit about the history of how it came to be, and then we'll talk about how we do acute care surgery at LA County. This is a picture of the first trauma surgeon in the world, and certainly the first in America. His name is George Goodfellow. He went out during the Silver Rush to Arizona, and where he practiced in Tombstone, Arizona, for 11 years. And while in Tombstone, he was asked to see a miner who was shot in a bar. And so he did the first recorded or published laparotomy for a gunshot wound. He treated a number of other people, famous people, Wyatt Earp and his brother Marshall Earp, at the gunfight at the OK Corral. He was the surgeon that took care of the wounded during that gun battle. And he published 13 different articles from way out there in the western Tombstone on the management of gunshot wounds to the abdomen. But outside of the Wild West, trauma wasn't really anything about gunshot wounds or stab wounds or anything. It was all about industrial accidents. And they accounted for about a quarter of all accidental deaths in America at that time, and a huge number of non-fatal injuries, 3 million back in the early 1900s. And a lot of these were fractures, and they occurred because of the railroad and the development and operation of the railroad, which spent large, I can imagine how much money that was in 1900 on injuries, much of it related to fractures. And so if you look at the history of acute care surgery and trauma in the United States, it all began with fractures. The American College of Surgeons Committee on Fractures was created in 1922. That later became the Committee on Fractures and Other Trauma, as other types of trauma began to emerge in the United States. And then in 1950 it was renamed the Committee on Trauma, which is its name at present. One of the most important things that the American College of Surgeons Committee on Trauma does is the Trauma Verification Program to designate trauma centers. And at present, that started in 1987. By 2003, there was almost 1,200 designated trauma centers in the United States, all with oversight from this committee. This is just a list of the requirements for level 1 trauma centers, and you can see all of these people, trauma surgeons, anesthesia, ER, radiology, ICU, all have to be in the hospital. A bunch of specialties that have to be 30 to 60 minutes away. You have to have an active research program, and all of this makes it unlikely for any private hospital to ever function as a trauma center because of the resources necessary. So, when the American College of Surgeons formed the Committee on Trauma in 1950, they found that there was a lot of work to do in the field of trauma, and that was highlighted by this National Academy of Sciences report from 1966, which was a 3-year review of the status of the initial care and emergency medical services provided to the injured in America. And it just reviewed some of the statistics. Trauma is the leading cause of death up to the age of 37 in the United States, and it's the number 4 cause of death across all ages. And in this report, Accidental Death and Disability, the National Academy of Sciences made recommendations on how to reduce some of that death and disability. Just some more facts about trauma in America: 52 million accidental injuries in a year, 107,000 deaths. 75% of these deaths occurred in rural areas where there were less than 2,500 population. 10 million temporary and 400,000 permanent disabilities, $18 billion in financial impact. In fact, trauma accounts for more hospitalizations than all births in the United States, and more than the care of all cardiac patients, and 4 times as much hospital resources as cancer care in America. So this was a huge financial problem, and it wasn't being well taken care of. So they made a number of recommendations, and we won't go through every one of these, but we'll highlight some of the important points from this landmark report in 1966. And the first of these is they made a specific effort to improve the emergency medical services at the state and local level. In 1966, when this report came out, there were no ambulance services in America, no formal ambulance services. In fact, there was no automobile or truck company that even made anything that was called an ambulance. And most of the emergency medical services at that time were mortuary vehicles because they were big enough to put a patient gurney in. So they served double duty, carrying people to the hospital and taking the dead bodies home. So one of the things that came about because of this National Academy of Sciences report was an organization to improve pre-hospital care. And now we have a system where every trauma center has a receiving area like this where they can, when an ambulance is dispatched to the scene, EMS notifies a control center, and they in turn can activate a trauma team activation, which we'll talk about in a minute. The other thing that this report did is it changed the focus of EMS from trying to stabilize and help the patient at the scene of the injury to what's now referred to as scoop and run. They just basically manage the airway and breathing and circulation, and they pick them up and get them to the hospital as fast as possible to try and improve outcomes. This is the organization of the EMS system in Los Angeles County. You see right here in the center of all of this is LA County and the metropolitan area. And here's County USC right in the center of it. There's 4 level 1 trauma centers and 9 level 2 trauma centers in the Los Angeles EMS region. So a trauma team activation occurs when a phone call comes in or a radio call comes into the dispatch center with a patient that has any of these criteria: unstable vital signs, gunshot wounds to the chest or abdomen, stab wounds to the anterior chest, if they're unresponsive, over 70, etc. And so the surgeon who's in the hospital, the residents who are on the trauma team, emergency room physicians, orthopedic surgeons, trauma nurses, and x-ray techs all respond to the trauma center to be there when the injured victim arrives. So the next recommendation of this report was to expand research on the management of trauma. It is the 4th leading cause of death in America. But it's not even in the top 20 in terms of funding for research by the federal government. Here's the breakdown. Research in trauma totaled $5 million at that time out of $1.7 billion that was spent on research. Very tiny amount. Cancer and cardiac disease each got $240 million, so you see the disproportionate amount. If you break it down by the amount of money spent per patient, it's 50 cents for every patient treated in terms of research funding, and compare that to cancer, where they spend $220 every year on research for every cancer patient that's diagnosed, $76 for cardiovascular disease. So a huge disparity in this major killer of Americans, and that's something that unfortunately persists now 50 years after this report. Some of the other recommendations: to improve the consistency of emergency room care and to develop accreditation for emergency rooms. And let's talk about that for a minute. At the time of this report, emergency room care was very inconsistent and disorganized in the United States. It was staffed by anybody that any doctor they could get in to staff the emergency room. Internal medicine and family medicine physicians who couldn't make it in practice would sign up for shifts so they'd get paid. And people who dropped out of residency programs, that's who was staffing the emergency rooms. There was no formal training in emergency medicine, and these people, they just basically triaged patients to other departments. And it was really the surgeon on call who took care of most of the important conditions in the emergency room. And then what happened is we had the emergence of emergency medicine as a specialty in the United States, and Los Angeles County Hospital was the origin of all of that. Dr. Gail Anderson came to USC about 1970 and founded the emergency medicine program in the old county hospital back here. There was no specialty of emergency medicine. He basically created it. And then 5 years later, then the American Board of Emergency Medicine was founded, and he became the first president of the American Board of Emergency Medicine. Today, there are 25 full-time faculty in the department, 99 voluntary faculty, and they train 54 emergency room residents. They have more than 500 patient encounters per day in the emergency department. It is the largest emergency room in the United States, 9,000 square meters, 109 emergency room beds. As I we have this low-dose spiral CT scan right at the entrance to the emergency room, so the trauma victims can be scanned very quickly and without leaving the emergency room. But at that time, emergency medicine wasn't the only specialty that wasn't providing organized comprehensive care. Surgery had some work to do as well. Until this advanced trauma life support system was created in the late 1970s. It was created by physicians in a group of private physicians in Nebraska, modeled after the ACLS course that also came from Lincoln, Nebraska. And this was adopted by the Committee on Trauma in 1979 as a way to systematize and organize the surgical evaluation and care of the trauma victim. They also recommended expanding ICU services so that once the patient got out of the emergency room and the operating room, they had a safe place to land. At that time, in the early 1950s, ICUs didn't even exist. In fact, they weren't common at all in the United States until the 1970s. Critical care medicine did not exist as a specialty until 1972. It was recognized, certificates in ICU were recognized by anesthesia, medicine, pediatrics, and surgery only as recently as 1986. But I wanted to share a couple things about the history of ICU care in the United States because I found them interesting. One of the grandfathers of ICU care is this guy, Bjorn Ibsen from Denmark. And he was working during the polio epidemic, and he developed a technique of intubation of the trachea and positive pressure ventilation during the polio epidemic instead of using the mechanical iron lung machines. But interestingly, once he put the tube in, they didn't have ventilators. So he had 200 medical students who took turns ventilating the patient by hand. And they did this for almost a year until this guy, Gunnar Engström, invented the first ventilator so they could replace the medical students from ventilating the patients. And he was the first to establish an ICU, and that was in Copenhagen in 1953. In the United States, the father of ICU care is this man, Peter Safar. He's an anesthesiologist. He established the first ICU in America at Baltimore City Hospital in 1958. And he established the first critical care residency in the United States at the University of Pittsburgh in 1962. He is a very important person in trauma and critical care for a variety of reasons. This man here is the guy who invented CPR. I don't know if you knew that or not, and interestingly, he took healthy volunteers, gave them paralytic agents, anesthetic agents to paralyze them, and then had volunteers give them mouth-to-mouth resuscitation to prove that it worked. That's an amazing study I can't believe they got away with. He also wrote a book called The ABCs of Resuscitation in 1957, and that concept of airway, breathing, and circulation has permeated ACLS and ATLS, and so a lot of credit goes to this pioneer in critical care medicine. Yes? So what he did is took the volunteers, gave them succinylcholine so they couldn't breathe, and then they did CPR on them to resuscitate. Yeah. So, one of the other recommendations of this study was to establish a national trauma registry, and so that was done in 1989. So all trauma and acute care surgery programs in the United States have to report to this ACS registry or data bank. Ours is the largest program, and we submit all of our information to this. we have 6 nurses who do nothing but extract data from the charts and code injuries and severity scores and enter all of that information into that trauma data bank. And then they also require a routine review of all autopsies on accident victims, and so we have this combined death review committee so that all services related to trauma meet once a month to discuss all trauma-related deaths, to make sure that all processes were appropriate and that we learn from our mistakes so that we don't repeat the same mistakes. So, after all of those developments in the 70s and early 80s, trauma care was much improved in the United States, and it led to what is referred to as the golden age of trauma surgery. At that time, general surgery residents in America were highly competitive. All of the best medical students wanted to become surgeons. And of the general surgery residents in America, the best and the brightest of them wanted to go into trauma. It was a glamorous life. These people would come in with stab wounds and gunshot wounds, and we'd rush them off to the operating room and literally save the patient's lives. There was also a lot of political clout in the realm of surgery because it was really the king of all surgery specialties at the time. And so it was a very desirable specialty. The problem is, over the next decade or two, a lot of things have changed and challenged the future of trauma as a specialty. And we'll go through each of these individually as we go on. The first thing is that the trauma patient in America started to change. Patients were not as severely injured as they were in the past. People are using seat belts, so there are much less severe auto accidents. A variety of reasons, but the patients were not as sick as they used to be, and I'll show you some data on that in a minute. And then there was also a dramatic change in the mechanisms of injury in the patients that we were seeing. So this is a paper that comes from the University of San Diego, their trauma center, looking at a 15-year period of time up until about the year 2000. They analyzed almost 17,000 patients looking at the mechanism of injury, severity score, etc. So here you see the injury scores in 1985 and 1999. It dramatically reduced in all head injuries, chest injuries, abdomens, you name it. So the severity of the injury of the patients that they were seeing in trauma was not what it used to be. This is that looks at the percentage of blunt trauma injuries. Now the reason that's significant is because most patients with blunt injuries never go to the operating room. They're managed in the ER and in the ICU. And you see a dramatic increase, a 50% increase in the number of blunt injuries per month at this level 1 trauma center. And correspondingly, a decrease in penetrating injuries from 19 patients per month down to 9, 12 stab wounds down to 6, gunshot wounds 20, only 25% as many gunshot wounds. That's good news from a society perspective. It's good news that we're seeing this improvement in the penetrating trauma. But it's bad news from the standpoint of the trauma surgeons because they don't get to operate, and they're surgeons. They want to operate.
Oh, excuse me.
Yes?
That means crime rate decrease?
Yes. So the crime rate from gunshot wounds, stab wounds, has decreased significantly.
犯罪自体が減って重曹とか思想の患者が半分以下に減ったということです。1980年代と90年代。Thank you.
Yes. So, in addition to changes in the mechanism of injury, which led to fewer operations for our trauma surgeons, there was also a change in how we manage patients with an increase in non-operative management, even of penetrating trauma. And Los Angeles County Hospital itself played a major role in this movement. And so I want to show you just a couple of the studies that came out of USC that have changed the way we manage trauma patients. Prior to 1997, when this report and a few others came out, if you had a gunshot wound to the abdomen, you went to the operating room automatically. Okay, there was no, it didn't matter what your condition was, you went to the operating room. Well, that changed after this report, where 309 patients treated over a year and a half. A little over half of them went to surgery because they were unstable. They had evisceration, other reasons that it was clear they had to go to surgery. But the rest of them, 106, so a little over a third of the patients, never went to the operating room, even with injuries like this, a gunshot wound to the liver. And only 5 patients out of this 106 actually ever needed a therapeutic operation. So what that did is it called into question the routine, take the patient to the operating room when they're shot in the abdomen, to following this algorithm that determines whether the patient goes to the operating room or goes for observation of the gunshot wound to the abdomen. Later that year, a gunshot wound study on gunshot wounds to the back. So here you see a gunshot wound to the back. It's sitting back here in the psoas muscle. And similar outcomes. 203 consecutive patients that were managed non-operatively, that presented for treatment. 130 of them were managed non-operatively, and only 3% ended up needing surgery. So now we have a situation where out of all of these patients, 600 patients in a year and a half at the trauma center, in the past all of them would go to surgery. Now 2/3 of the ones in the back and 1/3 of the ones in the anterior abdomen never went to the operating room. So now the surgeons aren't going to the operating room near as often as they used to. But it's not just limited to the abdomen. Here's a study that looked at penetrating injuries to the neck, stab wounds and gunshot wounds combined. Traditional protocol meant you took these patients to the operating room and explored their neck. But they found that only 17% of the gunshot wounds and 10% of the stab wounds actually required anything therapeutic at the operation, meaning the majority of the patients were explored for nothing, concluding that a selective non-operative management for penetrating injuries to the neck was appropriate. It's not only limited to penetrating injuries. This is a study on blunt thoracic aortic injuries. So aortic transections from motor vehicle accidents. And this study, this is not from USC, this is from the Journal of Vascular Surgery. And they looked from 1999 to 2011 at this trauma database, and they looked at the different grades of aortic injury. And look at this, 93% of these patients were managed non-operatively. 100%, well, it's only one patient. Even grade 3 injuries, 1/3 of them were managed medically, which is an amazing thing to me. Back in the day when I was a resident in training, the dogma was if you had a tear in your aorta, you had to have that fixed right now or you would die within 24 hours. Well, it turns out that's not true. And a large number of these patients never go to operation. And here's the data from their study. So 28 never had an operation, 31 did. The interesting thing is that even the ones who go to surgery don't go to surgery with a trauma surgeon anymore. Now they go for vascular surgeons and they do endovascular grafts to repair these thoracic aortic injuries. So in reality, none of these patients now are going to surgery by the trauma service. So all of these things combined, when you look at this is a typical change in what's occurring in trauma. This line up here, that's orthopedic. They're still operating. There's broken bones and things that need to be fixed. This right here are laparotomies for trauma. Look at the dramatic decrease. Thoracotomies, craniotomies. So all of this stuff way down low here compared to 15 years prior. So the operative experience of the trauma surgeon is really low. This is another study looking at the same thing. From 1999 to 2002, only a 4-year period of time, 18% of the trauma patients at this center needed an operation. Now it's down to 13. That's a 26% decrease in the number of patients going to surgery over a 4-year period of time. So not only are we not operating on patients, but when we are operating on them, they're going for endovascular repairs, as I mentioned. Cardiothoracic surgery is now fixing heart and lung injuries at most centers instead of the trauma surgeons. The other challenges to the future of trauma is that it's largely nighttime work, and the current generation of residents don't like that idea. The generation Y or W or whatever we're in now, they don't like this only nighttime work. And all of these factors together have led to a severe decline in the interest of students and residents in a career in trauma. This was a study done in the 1990s. They did a questionnaire of general surgery residents, almost 1,800 of them, to find out their perspectives on a career in trauma. Remember, I said in 1980 this was the #1 specialty. It was the most sought after. It was the golden era. 2/3 still agree it's a rewarding field, but only 18% of them now wanted to pursue a career in trauma. And there are several problems that the students saw with the specialty. I showed you too few operations. They want to be surgeons. They don't want to be in the emergency room in the ICU. Too much night work. Negative patient factors, the perception of that these patients are not desirable patients to have. And it interferes with any elective operating schedule that you might have. So for all of these reasons, interest in surgery, or in trauma surgery, has gone way down. Here's you see the number of applicants. This is emergency medicine for comparison. You see there's a lot of interest in emergency medicine amongst medical students in America, but not trauma surgery. Only 40% of the training spots in trauma and critical care in the United States were being matched. It was estimated that by the end of 2020, we would be short trauma surgeons, 1,500 trauma surgeons, that there would be unfilled positions around the country. So all of that together led to a crisis, really, in the career in trauma surgery in America. And these are all presidential addresses of the Society of Trauma, famous trauma surgeons from the United States, and the theme is clear. The specialty of trauma surgery is in real trouble for all the reasons that I mentioned. At the same time, hospitals were struggling with a different crisis, and that is the emergency non-trauma surgery. Things like appendectomies, gallbladders, bowel obstructions, all of the other stuff that's not trauma-related that comes into the hospital. And there's a lot of reasons why this was a major problem in the United States, but the first of which is population continues to grow and it's getting increasingly older. So utilization of the emergency department for acute surgical emergencies continues to climb year after year. We have a shortage of surgeons in the United States. The estimates are, public health estimates are, that we need 7 general surgeons for every 100,000 people in the population, and currently we only have a little bit under 6. So there aren't enough surgeons to go around, and we can only produce a little over 1,000 a year. Even at maximum, the most we can do is 1,500. So it's going to be difficult, if not impossible, to catch up. We're just basically short surgeons in the United States. The next factor is that the people who are going into surgery are going into specialties. More than half of them go into a fellowship. So they're not interested in doing emergency care. They're not interested in doing gallbladders and hernias. They want to be doing lung surgery or esophageal surgery or some vascular surgery, whatever. And the last factor is, I mentioned the other day when we were talking that almost half of the graduates of surgery programs in America are women. And it has been shown that they do fewer operations when they're in practice than their male counterparts. By a significant amount, a quarter less, 25% less cases. So now we're short surgeons and half of the surgeons do fewer cases. So it's a real problem in terms of taking care of all of these surgical emergencies that aren't trauma related. In addition, our management of these is not nearly as organized as trauma. There is no such thing as an ATLS book for emergency surgery. It's more haphazard care. And the hospitals are left to rely on what we call call panels, surgeons who basically volunteer to cover the emergency room at night and on weekends. The problem is the people that volunteer for these are the young surgeons, because they have time on their hands. They're less talented surgeons because they're not busy, or they're foreign trained surgeons who come into the United States and practice in the emergency department. The experienced surgeons are reluctant to take call in the emergency room. And the reason is because it interrupts their elective practice. If they're up all night operating, they have trouble the next day operating, if the clinic schedule is delayed. There's a lower level of reimbursement, 15% of all Americans have no health insurance. And a lot of them get their care through the emergency room. So on average, if you work in the emergency room, you give away $200,000 per year in free care. It's also riskier from a liability perspective. Uninsured patients are more likely to sue in America than people who have insurance. There's a lot of reasons for that, but it is a fact. So the experienced surgeons don't want to work in the emergency room. The next issue is that hospitals are closing. From 1993 to 2003, almost 80 hospitals closed in California and 700 of them across the United States. And it's because of low levels of reimbursement from Medi-Cal in California or Medicaid in other parts of the country. It's estimated that at present 80% of all hospitals in California are losing money. The only way they stay open is because of donations made by philanthropists to keep the hospitals open. And this is only going to get worse as the population gets older. Emergency room visits are estimated, have increased about 26% on an annual basis in the United States. Yes?
That's results from the
That the hospital's losing money? Yes. Yes.
Government pay this.
Yes. Yes. Right now, the government, for government assistance, Medicaid, they pay 60 cents out of a dollar's cost. So the hospital loses 40 cents of every dollar on the care of these patients.
Thank you.
So, what is non-trauma emergency surgery? This is a review that was published in 2014 that looks at the scope or the types, the volume and types of procedures that come into the emergency departments across the United States. The nationwide inpatient sample is a random collection of data from all hospitals in the United States. So it's representative of what's going on in America. These emergency general surgery non-trauma cases account for 7% of all hospital admissions in America, 1,290 admissions per 100,000 people, and 29% of them need to go to the operating room. And these numbers are increasing. These are the number of emergency surgery cases, and this is the percent of all admissions, so both. They're both going up in number and in percentage. Now, emergency surgery admissions account for almost 8% of all admissions to acute care hospitals in America. And in fact, if you break the numbers down, whoops, sorry about that. Emergency general surgery admissions, 1,200 per 100,000 population. That is more than coronary artery disease and cancer combined. This is a huge volume of patient care and resource utilization at the hospital, and it's at risk because there aren't enough surgeons to care for it, and emergency departments are closing. These are the types of procedures. 40% or so, or excuse me, 25% or so are hepatobiliary and pancreatic, acute gallbladder disease, pancreatitis. About 15% upper, lower GI and bowel obstructions, and then the rest is hernias, vascular, cardiothoracic things, 3 to 5% each. So these are the typical sort of patterns of emergency procedures we see. At LA County, our acute care surgery service, our non-trauma emergency experience is a little bit different. We have 3 teams that have attending surgeons, senior residents, and junior residents on them, and those teams saw 15,000 consults over a 4-year period of time. So that's 3,674 consultations for emergency surgery in a year. That's almost 11 per day, and 82% of them came through the emergency room. 86% of these had to be admitted. 38% of them ended up with an operation. So it's a huge volume of not only consultation and evaluation, but surgery on these patients. Much of it at night and on the weekends, and laparoscopic procedures now account for about 40% of those operations. In our experience, appendectomy is the most common reason. There's 1,924 appendectomies done through this service, 1,600 cholecystectomies, and hernia repairs are number 3. So that's sort of the major portion of what the acute care surgery service does at USC besides trauma. So, because of these things, the crisis that's occurring in trauma care, the lack of attractiveness of the specialty, the experienced surgeons ditching out, the American College of Surgeons formed a committee called the Consideration of Trauma Specialization in 2002, when all of these problems were coming up. And they were focused on getting access to emergency surgery care and the future viability of trauma as a career. So the 2 problems that we just talked about were the focus of this committee. That was renamed a year later, the Committee to Develop Reorganized Specialty of Trauma, Surgical Critical Care, and Emergency Surgery, and that finally became the Acute Care Surgery Committee in 2005. So a new specialty in America was born. And that was with the first acute care surgery program at University of Nevada in 2007. Later that year, 6 others joined, so these are the original acute care surgery programs as of the end of 2007. As of today, there are 16 training programs in acute care surgery in the United States, and they're all listed here on this slide. This is the typical curriculum of an acute care surgery fellowship, so they'll spend 6 months doing ICU. They'll spend 15 months doing emergency and elective surgery, and then there's some extra time in there, about 3 months, where the programs can decide what they want to do with the trainee. During the 15 months of emergency and elective surgery, they're supposed to get experience in all of these specialties. So the residents would come, for example, on a thoracic surgery experience to learn how to do lobectomies, to do how to do esophagectomies, so that when they have to do it in the acute setting and in the trauma setting, they know what they're doing. So that's the idea behind the training programs. And interestingly, this system, this new acute care surgery training paradigm and patient care paradigm seems to be working. It has led to a revival of interest in the medical students. So this is published in 2012, so about a decade and a half after that previous study I showed you. And now trauma is the #2 career choice amongst medical students as their first choice for a career, and it's #1 behind orthopedic surgery as their second choice of a career, and if you list down to third choice, it's again #2. So medical students are coming back to the field of trauma and acute care surgery because of these changes. And the reasons listed by the medical students are shown here. And the interesting thing is that if you look down here at the bottom, none of these things existed before. Reimbursement wasn't very good. Predictable work hours were terrible. Minimal night and weekend call, that didn't exist when you were a trauma surgeon. That's all you did. So these areas are now looked at as pluses by the students because of the changes that have occurred. Patients are also benefiting from the acute care surgery model. And I don't have time to go through all of the studies, but this is one of the earliest that looked at the time to operation in the acute care model versus the traditional model of care in the United States. And the number of operations that were done during regular hours increased during that time period. So the surgeons didn't have to wait until their elective operations were over, or until their clinic was done to take care of these emergency procedures. They were able to do them real time because they had a team in the hospital able to take care of them. Surgeons are benefiting because they're doing more operations. So here's from 2001, before at the beginning of their ACS experience, to 2003. And what you see is that the total number of trauma cases hasn't really changed much, okay? But what did change is the number of emergency general surgery cases went dramatically up during this time period. If you look at the operations, the trauma volume more or less flat, but a significant increase in the general surgery and emergency general surgery cases. So the surgeons are happier because they're doing a lot more operating. So they're getting excited again about the specialty. Hospitals also benefit in the form of lower costs. If you look at the results of cholecystectomy before and after this ACS model was instituted in this article from 2014, the median time to OR was shorter. The percentage of patients operated on within 24 hours was higher. Those operated on during the night was higher, and they had a shorter length of stay by 1.4 days because of all these things. So the cost savings was $1,000 per patient. And all those data are shown in this table here. So $1,000, which is about 12% of the total cost, was saved by the acute care surgery model. And these are just a listing of other studies that have looked at before ACS and after cost savings of $13,000 here, $9,000 here, $8,000 in this study. So you see dramatic cost savings to the hospital by this model as well. So everybody's pretty excited about it, and acute care surgery, I think, is here to stay. So at USC, how do we do it? Our acute care surgery model We don't have a training program as yet, because there's some things, some steps you have to go through to apply for that, but I think it'll be coming in the next year or so. But that's how we take care of patients. So we have 4 acute care surgery service teams. Each of them has 4 residents and 2 faculty that are in the hospital for 24 hours a day, 7 days a week. They cover the emergency room, the trauma, and full-time coverage of the ICU. And they rotate on an every 4-day basis. And then, of course, there are specialty surgery services that are available as needed. When we changed to the acute care surgery model, there was a 380% increase in the number of operated cases on the acute care surgery team. So again, it's like the data I showed you before, the surgeons are happy as can be because they get to operate. And 72% of the cases are non-trauma surgical emergencies. So those sort of orphan patients are now being taken care of. Here's just a breakdown of the types of trauma. We don't really have to go through that very much. These are the emergency non-trauma admissions. I showed you these data. It's about 9 per day. Major operations 3 per day. Minor operations 2 to 3 per day. Lots of appendectomies and gallbladders. This is a photograph of the acute care surgery team. This is just the faculty. This doesn't include any of the residents. So you can see it's a large group of faculty as well as a number of nurse practitioners that are all involved in the care of these patients. Acute care surgery has also emerged as a real strength in the education program in our department as well. Because we have all of these faculty members who don't have to be distracted by private practice and trying to earn a living. Their job is to be at the hospital and work with and teach residents. And it's really been a great thing for residency training. And they participate very heavily in the skills lab. They have animal models for trauma, a bunch of simulators. One of the simulators that's really a great thing for our residents is what's called the MEDI human simulator, human patient simulator. It was created by the Department of Defense to train medics and military physicians on how to manage trauma victims. So this little mannequin down here can simulate all kinds of injuries and changes in vital signs that show up on a monitor, and the team taking care of them has to respond to those things real time, and they get feedback. And the whole thing can be videotaped. There's little cameras up here in the corner so that they can work on team training as well. We have an animal lab that the trauma service uses extensively to do a variety of skills lab sessions, some of which are listed here. So you see there's a lot of education that goes on this service, given the breadth of the trauma and non-trauma emergency care associated with acute care surgery. And the last, but certainly not least, is our fresh tissue dissection lab. We have a special arrangement with the coroner's office so that we get any unclaimed bodies from the coroner rather than them being buried in a mass grave, and they're used for educational purposes. So we can actually perform real operations rather than just working on simulators. There's no risk of harm to the patient, obviously, because they're deceased, and it's really unparalleled by any surgical simulation that might be available. And this is a listing of the procedures that are done by our acute care surgery service on these cadavers. And you can see all different types of trauma, exposures, chest tubes, fasciotomies, all of the types of things that our residents need to know when the trauma victims come in. They get to practice ahead of time on these cadavers as part of their education program. And then finally, we have a number of conferences that are also focused on acute care surgery. That's part of the education of our residents. So just to give you an idea of what the typical day is like for an intern on the acute care surgery service in county. Pass-on rounds occur at 7:30. That means that the resident comes to the hospital about 5:30 to see all of their patients before these pass-on rounds occur. Pass-on rounds are a way to run through the list of what happened the previous day, the pending operating cases, and the discussion of any consults to ensure a proper transition of care between the service that's changing in the morning. So all of the faculty, 2 pre-call and 2 after-call faculty will be there. All of the residents, so there's 8 of them, nurse practitioners and medical students. So you can see a room full of people gets together every morning at 7:30. They review their cases, discuss the consults, and transition patients for care. This is a list of the activity of the acute care surgery service in a 24-hour period of time. Well, this was about a year ago that I collected this. I was actually one of the faculty members on call this night. We had a busy night. We had a car accident that hit a pedestrian, went to surgery. Gunshot wound to the liver, went to surgery. Acute cholecystitis, had a LAC+USC. Necrotizing fasciitis, had a debridement. We still had a gallstone pancreatitis, another necrotizing fasciitis that were waiting to get into the operating room. We didn't have time to get them done. And then we had some consults for abscesses, abdominal pain, and you see the list. We had a gunshot wound to the chest that we were managing non-operatively, perforated cecum that was admitted to the ICU. The list goes on, and it carries on. So what is that, about 25 consults on the acute care surgery service, including 4 more motor vehicle accidents that were blunt injuries that were being observed. After pass-on rounds, they will go to the operating room where they're doing emergency cases all day long. They have ICU rounds at 9:30 for the members of the team that are not in the operating room. Then we have discharge planning rounds. Those are multidisciplinary to get patients on their way to discharge from the hospital. And then a bunch of educational conferences, many of which I've mentioned that occur in the afternoons. So to summarize then, acute care surgery in the United States and in LA County, modern trauma care in the United States and in LA County has had a relatively short, from 1950 or so, but illustrious history. But the golden era of trauma surgery as a specialty is unfortunately gone for the reasons that I mentioned, and that traditional model no longer works. But thankfully there is a solution, and that is acute care surgery, which combines the specialties of trauma and non-trauma emergency care along with intensive care to really make an exciting option for surgeons as a specialty in the future. Thank you.